Welcome everyone to this IAQM webinar, Cleaner Air, Healthier Hospitals, Implementing the UK's Clean Air Hospital Framework. This is an IAQM webinar, and the IAQM, or Institute of Air Quality Management, is the professional body for air quality professionals. We act as the voice of air quality by producing guidance on matters affecting air quality professionals and respond to government consultations. You can find out more about us on our website, and I'll provide a link to that in the chat once we get started. We are delighted today to be joined by Tunde Okiowo, a third-year PhD student at Northumbria University, researching sustainable approaches to improve air quality and reduce emissions in hospitals. At the end of Tunde's presentation, we will have some time for Q&A, and as usual, you can submit these questions at any point during the presentation just using the Q&A function, which you should find at the bottom of your Zoom screen, and I will then read these out on your behalf later on. Tunde, thank you so much for joining. I'll pass over to you.
Thank you so much for having me there, Ashley, and thanks for the beautiful introduction. You'd observe that I've added a bit of an add-on to that title at the RVI and Freeman Hospital, just to put some more perspective into it. You're welcome to this webinar. I'm glad that you could join. My name is Tunde and Okiowo. Ethne had a good attempt at pronouncing the name. You did a good job. Well done. Thanks. Right. So my research is, I'll be making a talk today looking at the Cleaner Air, Healthier Hospitals, implementing the UK's Cleaner Hospital Framework at the RVI and Freeman Hospital here in Newcastle. But before I start, I'll just share a little story with us. And that's the story that I heard from a master storyteller. He's a minister, J. John. You might have heard of him. He's told the story of a factory worker who after the day's work, sometime he put a box in a wheelbarrow and gathered wood dust because he worked in a place where they had wood dust as a part of the waste material. The wood dust was meant to be disposed of. So he put it in a little box, put the box in a wheelbarrow and was wheeling it out, presumably taking it to his house. He was stopped at the exit of the facility by the security operative saying, "Why are you taking this out? What are you having in that box?" He said, "It's just wood dust. I want to throw it away. It was meant to be thrown away, but I want to use that home. So I'm taking it out. Just stay with me, okay?" So he said that was it. The security person said, "Oh, that's kind of suspicious. What do you need wood dust for? Open it, let me see what's in the box." And the gentleman, that is the factory worker, opened the box and voila, it was wood dust indeed. And there was nothing more than just wood dust. And so the security person was surprised and he said, "Okay, that's fine, you're free to go." The next day, the same thing happened. Another box of wood dust in a wheelbarrow and was being wheeled out. He was stopped, checked, same wood dust, nothing incriminating. The third day, and then on it went for the week. The security person then had to ask this factory worker exactly what's going on. "I feel something fishy is going on. You can't just be taking wood dust in box out. What exactly is going on? Tell me. I won't accost you for it. Just confide." And so the factory worker said, "I will confide in you. And I'm actually not taking the wood dust. I'm actually stealing wheelbarrows." And that's what's been happening for the past few days. So he's been stealing wheelbarrows. Excuse me. He's been stealing wheelbarrows, and there he was, people thinking he was taking wood dust. And the reason I've told this story is because sometimes we're fixated on the things that are small when the big things, the big pictures are right before us and we are missing it and someone's stealing our wheelbarrow. In this instance, as pertaining to the webinar today, the wheelbarrow is the quality of our air. It's been robbed of us. It's been robbed. It's been taken away, and we are looking at it. Lots of people looking at it. We're not doing something active enough. And so I've told this story to give the perspective to what I'm talking about today. It's IAQM, so I know that there are lots of people on the call know about air quality and pollution. But for me, it's more than just a research. It's a personal venture to contributing something impactful. Would you know, believe it if I said that about 215 trusts in the UK there are, but most of the hospitals within this trust are within areas of PM 2.5 concentrations above watered organizations. But that's the reality. Research shows that many of these hospitals are in areas with PM 2.5 concentrations above the guideline of the WHO. And air pollution, as we know it, consists of many pollutants, some of which include PM 2.5, PM 10. Those are particles in the air, like the dust I just mentioned about, could be, but the different sizes, PM 2.5 will be those with aerodynamic diameters of less than 2.5 microns, and PM 10 will be those with less than equal to 10 micrometers. And then there are other pollutants like nitrogen dioxide, carbon dioxide, and the VOCs, volatile organic compounds, and the likes like that. My project, my research focuses on PM 2.5, PM 10, and nitrogen dioxide. And it's amazing that the hospitals are not just in these locations with poor air quality. They are also contributors because these sources of what we do are attributable to some of the things that are going on at the hospital. For example, transportation, which is a main source of pollution as we know it. It is heavily tilted to the hospitals. And research has shown that about 5% of global greenhouse gas emissions are attributable to healthcare system. In developed countries or high income countries like the UK, for example, these percentage could reach as high as 6%. It's also interesting to note that research shows that the NHS travel and transport accounts for about 3.5% of UK's road traffic, and that's quite significant. And it highlights the fact that the hospital has a lot to contribute in improving air quality within our society. Air quality, as research has shown, is beginning to exacerbate the burden of disease in our society. The World Health Organization says that about 43% of deaths and diseases from chronic obstructive pulmonary diseases are attributable to poor air quality, 24% in stroke, 17% of deaths and diseases from acute lower respiratory infections are attributable to this poor air quality that we're talking about. It also attributes to about 29% in lung cancer. And it's quite alarming to see these figures and statistics. It ranges across all ages without any divide. The reason I have said all this is to highlight the fact that there is need for actions, and it's not an action that's just domiciled with just a few people. It includes everyone, including the hospital. Yes, the very same systems where we are supposed to go for care. And so my research looking at the Clean Air Hospital Framework, opportunity to have the Newcastle NHS Trust implementing the Clean Air Hospital Framework as a part of their commitment to improving air quality within the hospital. And that's where I come in the Clean Hospital Framework I will talk about now. The framework itself was designed by the Great Ormond Street Hospital in partnership with Global Action Plan, and it's designed as a self-driven support mechanism framework to support hospitals towards improving air quality in their vicinity and even impacting on their community. And it focuses on 7 key policy areas, as we can see on your screen there: travel, procurement, design and construction, energy generation, local air quality, communication and training, and outreach and leadership. These 7 policy areas are weighted as I have categorized on the screen there. There are 215 actions in total, but they are categorized into all the 7 key policy areas. And the idea behind the framework is that there is the action, the hospital looks at the actions and they implement it. And then once the action is being implemented, it's able to assign a score to those actions. At the end of the day, it's able to achieve levels of achievement, weighted achievement within the framework, ranking from starting out and then going on to getting there and going on to good and excellent. At the Newcastle Hospital, the hospital is aiming for 70% compliance with the framework, which is the excellent mark within the framework. I'll give us a little bit about the general feel of what the framework looks like. The travel part of the framework subdivides or categorizes all actions of 61 actions within that division into 7 key areas, looking at hospital travel planning, walking and cycling infrastructure within the hospital, zero emissions vehicle infrastructure, parking for all vehicles, travel to and fro, and routes to minimize travel, and then reporting. Those are the categorization of the actions within the travel. Because of time, I won't go through all of these one by one, but I just have focused on the travel. But I'll give us an idea of what other actions within the framework could look like. From the 215 actions, I've picked up one action each within each one of the categories of the focus areas of the framework. And that I would talk about, say, for example, in the outreach and leadership bit here, it says that the action says that the hospital is a key partner in local groups and is committed to developing initiatives and strategies to improve public health. And you'll see how these come together in some of the data and statistics I'm going to be showing to us later in the presentation. And you see how significant these can actually be. Right. Having said that, we'll see that these 215 actions have a heavy demand on the resources that are available to a place like a hospital or even any organization as that, meaning that there is a need to be strategic about the approach. So the approach I have taken to implement or support implementation of this framework within the Newcastle Hospital is to develop a prioritization matrix. The prioritization matrix is one that have called up with extensive stakeholder engagement within the hospitals. What we have done is to do an analysis of all 215 actions and review them based on the impact that each of these actions would have and the ease of implementing all of this. And it has the advantage of, one, helping stakeholders across the hospital be aware of the implementation of this framework, because as you would agree with me, the NHS is a very large organization with several departments and doing many multiple activities. So it's important. It could be a Herculean task integrating everyone into focusing on this framework. But these activities, such as the engagement, helped to bring about the awareness within the hospital itself. All actions were ranked, and then we came about this framework and the categorization, focusing largely on the high impact or the high impact, high ease of implementation, all the way down to low impact and low ease of implementation. And of course, the prioritization will focus on the high impact and high ease of implementation. Therefore, after having done that, we had to audit where we stand. When I joined the team, the hospital was at 17% compliance with the framework, but after optimization of actions within the framework, the hospital currently stands at 38% compliance with the Clean Air Hospital framework and the actions that are in it. And you can see on the screen right there, that is the status as we speak right now. That in the travel, the hospital is doing quite well, above 10% of the expected compliance of about 25% within the framework. But we're struggling at the hospital with two key areas, and that's the energy generation and the procurement. And one of the key reasons for that is because there are some legacy issues involved. The hospital signed into some contracts, say, for example, contracts that have been signed in at the hospital many years before the implementation of this framework. The hospital is unable to pull out of it because it will mean significant penalty will be paid or fine. And moreover, the contract is nearing the end of it. So we would have to stick in there until the contract is done so that we can then optimize it. But such are the issues. And one of the things I would highlight, therefore, is the significance of contracting in improving air quality. Because if you go ahead and sign a contract without putting necessary facilities or infrastructure in place to assure or ensure air quality is not sabotaged, then you might be stuck into something that you would find hard to pull out of at the end of the day. If we would focus on the high impact and high implementation of the prioritization matrix that I showed to us earlier, we will be able to achieve 61%, which will be a long shot away from 38% where we stand right now. But we would need a contribution from improvement from all actions within the framework. Procurement we need to drive up a lot more, and the energy would also need to improve. But even without the contribution of all of this, if we would at least implement all these high impact and high ease of implementation, the low hanging fruits, it will take us a significant way to achieving the excellent status that the hospital desires to have. I'm going to then go on to see how then do I piece all of this together to see what is the impact on air quality. My research looks to evaluate the clean air hospital framework in part as well to see if it does deliver on its promise of improved air quality. And so I have implemented an air quality monitoring strategy within the hospital where I have installed over 40 quality monitors across the RVI and the Freeman Hospital. And on your screen there, the RVI and the Freeman Hospital layout, where you can see some colored dots showing locations of different hospitals. The monitoring that I'm doing implements a wide range of monitoring sensors to provide temporal and spatial resolution across the hospital. And some interesting results have been coming up from those monitoring activities. Some of the monitors have been up for excess of about 2 years, while some have been there for less. And here is a snapshot of the kind of monitors that I'm using on the project. The indoor air quality monitors are the popular air quality monitors monitoring PM 2.5, PM 10s. The diffusion tubes are used for monitoring the NO2 across the estates of both RVI and the Freeman Hospital. Each one of these estates occupy a square kilometer of about 0.14 square kilometer individually, making a total of about 0.28 square kilometer. That's 0.28 square kilometer together as a hospital. I'm doing ambient air quality monitoring from an urban observatory monitoring unit that we are partnering with. That's a monitoring unit from Urban Observatory at Newcastle University. And those are the monitors. So after doing all this monitoring, we're also partnering with the government because there's a need to understand what the background monitoring says. So look at the pollution at the hospital, and the background monitoring that we have from DEFRA shows that there is a correlation between both pollution at the hospital and the background monitoring. As we can see on the screen there, is a correlation plot between background monitoring at St. Mary's. There's a monitoring unit by the AURN monitoring unit at the St. Mary's location, and then the RVI has its own monitors, one of my own monitors that I'm utilizing. And you can see there's a strong correlation between background and pollution at the hospital. What we would also observe is the fact that no matter how much we try to improve air quality at the hospital, we might struggle because there is a lot of pollution coming from the background, hence highlighting the need for collaboration and collaboration with anchor institutions around the hospital as well. So we can't do this on our own. We have to do it together. And that's what this data reveals as we can see. Ambient air quality monitoring at the RVI, for example, showed that highlighted the fact that the morning hour rush hours at the city center and the evening hours rush hours are evidently shown, displayed, captured in this plot that I have shown here. And it shows that the morning time, you can see the peak of NO2 being the red lines that we can see there on a weekly day-on-day plot. And then you can see the evening time as well, showing the peak of the NO2 as well. It highlights the fact that the movement of people on the road is contributing significantly to pollution at the RVI. Similarly, indoor air quality monitors show a pattern that's quite interesting. And this plot that you are seeing right here is monitoring of indoor air quality at the Freeman Hospital. It shows that there is relatively plain, regular or stable um, concentrations of PM 2.5 and PM 10 at the Freeman Hospital. The plot you're looking at is PM 2.5 actually, but it's showing plots across different locations within the Freeman Hospital. Interesting point I would want to point out, however, the peaks that we are observing in the evening times, it shows that there is something that's causing a peaking of pollution in the evenings, particularly on the weekends. And I'm inquiring into this. What I am observing, and from the engagements I have done, is that it might be something akin to a high footfall in the evenings, and that's quite an interesting find to know. The same system, the same readings, similar readings, I have also seen at the RVI, which is a long way away from the Freeman Hospital, but a similar result I'm also observing at that point. Another approach I am looking at in my research is that how can we improve the air quality without necessarily trying out all of these activities, or perhaps we could better optimize the actions that we have and try it out first before we go on to implement it. And so I am also implementing the use of the ADMS monitoring and also doing a computational fluid dynamic modeling of the RVI and the Freeman Hospital. And this gives the advantage of simulating the environment of the hospital and then trying out some of the actions that we are hoping to implement or policy changes and seeing how it translates into air quality, air pollution, or the result of the monitoring that we are seeing on site. So on the one side, I have the on-site monitoring. On the other side, I have the mathematical modeling utilizing softwares like the ADMS and the CFD-based softwares. In my case, I am using Panache Fluidine, which is a CFD model. This on your screen right here is a pre-model of the RVI showing the dispersion of NO2 within the premises. It's quite interesting to see how the dispersion model occurs because what I am trying to do is that I would then optimize this mathematical model and try and make it to equate what I am seeing on the on-field measurements that I am doing. At the end of the day, when we have a fully optimized model, both on the ADMS and the CFD based model, then I'll be able to trial out some of these actions and see how it results in a change and improvement in air quality. Then we can translate these actions into a real-time, real-life implementation at the hospitals. The reason for the need for optimization is because initial trials of the models and comparison of model results and the on-field monitoring shows that there is a disparity between what is being monitored and what is being modeled. And of course, that just gives us the opportunity to optimize this, as I have earlier talked about. Some of the monitoring results as well at the hospital highlighted the fact that there's been a lot of exceedances from the compared with the World Health Organization guideline values from the monitoring that I'm seeing at the hospital. But then, of course, that's the whole idea behind implementing the Clean Air Hospital framework. And these actions would help to further reduce the pollution on site, provide a cleaner environment for the people, the staff, and the patients at the hospital. Finally, I would want to talk about some of the impacts that I've been able to make from these activities at the hospital. I've been able to contribute to national policy discussions, influencing the UK's Clean Air Act. For example, I was able to contribute at the Labour Congress discussions on the UK's Clean Air Act late 2023. And also, the hospital has been able to drive a campaign to improve air quality within and awareness of pollution within its staff members. There's an ongoing activity that we are trying to implement where healthcare professionals are able to integrate air quality advisory into their own routine. But then that is still at the early stage of its implementation, still being looked at how to implement that. We've been able to go ahead and sign a no smoking, a no idling policy in collaboration with some of the anchor institutions within the Northeast, driven by the awareness by this clean air hospital framework. And I also collaborate with major other NHS trusts to implement the clean air hospital framework trust to ensure that this framework is being implemented across the NHS, and then we can jointly evaluate how it's contributing to improvement of air quality within the hospitals. Finally, and one of the engagements I have had, I was able to have a chat with some young people at the hospital. And the picture that you see on there is the painting that was done by one of the young children that came by the stand when we had that engagement. And the message on there is very clear. It says that clean air for good health. Let's have happy days with cleaner air. And I believe that if we keep resonating these awareness amongst both patients, staff, and visitors at the hospital, we are not only able to drive on improvement in air quality at the hospital, we're also able to impact on the community through the people that we come in contact with. And that's been my experience implementing the Clean Air Hospital framework at the NHS Trust here in Newcastle. Thank you. I'll put a stop to it there. And thank you.
Thank you so much, Tunde. That was really interesting overview of kind of how you've been putting the framework into practice and monitoring its effectiveness. So thank you so much for that. And to all our attendees, please do put your questions in the Q&A box for Tunde, and we'll get to them when we can. So just to kick us off, I wonder if you could provide a bit of background, Tunde, on how the framework was initially developed, and kind of you mentioned that it's being implemented in some other trusts, and are there plans for this to go even more widely? Would you like to see this across all trusts?
Yeah, absolutely. So the framework, as I did mention, was developed by the Great Ormond Street Hospital in collaboration with the Global Action Plan. And the influence to it is that you would understand that London, these two are based in London, where there is heavy pollution challenge there. The implementation of the clean air zone in London and all other interventions that has been implemented in London. However, not before then, there was no real focus on hospitals' intervention or bit in contributing to improvement of air quality. But on the back job of realizing that the hospital also has a role to play, therefore the need to do a framework like this. Hence, both organizations collaborated to bring about this framework. There is also the ICS framework, which some people on the call might have heard about. The ICS framework is it's another model that came after the Clean Air Hospital framework, still on the platform of the great the GAP there, Global Action Plan. There you go. I've said that multiple times. It wants to run from my mind right now. But then they had developed that to allow the ICS, which is the wider NHS, to collaboratively implement air quality improvement strategies across hospitals rather than focus on a single hospital. But the Clean Hospital framework has the advantage of allowing hospitals, each hospital in itself as an entity, to drive or champion the cause of improving air quality on their own without having to lean on other hospitals. And by that, perhaps they can take on the leadership role and also make the work of integrating and improving air quality strategy much easier.
Great, thank you. And what have been some of the key challenges of implementing the framework that you've come across whilst you've been working in this area?
A couple of challenges I have come across. The NHS, as I mentioned in the presentation, is quite a large organization, and that in itself is a huge challenge because whilst there are many people driving air quality improvement strategies, there are so many goals that they are having to implement. There are so many targets that they are having to keep up with. Plus, their primary role will be to save lives, isn't it? And so to ask the hospital to channel funds into some of the initiatives and the interventions may be a high ask a couple of times. And the way I've tried to approach that is that prioritization matrix where I spoke with the stakeholders within the hospitals because so that prioritization matrix in the real sense of it is very much tailored to the NHS at Newcastle. And much as it can be implemented widely by other NHS trusts, which some have done, it is very much tailored to the NHS trust in Newcastle. Why? Because the resource availability to each of the hospitals differ widely, the ease, the impact that it will cause within each of these locations would also vary equally because of different variables like the space that they occupy, the footprint of the organization, the kind of equipment that they utilize, and the resources that are available to them as well. So much as the prioritization matrix can be implemented by all NHS trusts if they choose to, because they have the back end where they can also fine tune and adjust the impact and ease of implementation model that I have developed. Yet it is very specific to a hospital that is implementing it, and that's one of the key challenges that I have observed and how I overcame it.
That's really interesting. Thank you. And kind of building on that point, how have senior management in the hospital trust responded to the data? And what do you think would be the most significant intervention that could reduce air pollution at this particular trust?
Right. I mean, I think that the NHS Trust in Newcastle was quite fortunate to have, is quite fortunate to have a support of top management. And I should mention and highlight that in 2019, the NHS Trust in Newcastle became the first healthcare institution to declare a climate emergency in the world, actually. And ahead of the implementation of the national NHS Green Plan, and they had already declared a climate emergency in that 2019 and started working on improving air quality as one of their key goals and on reducing carbon emissions and also reducing waste. So they have three major goals that are part of the improvement plans, air quality improvement, carbon emissions reduction, and waste management, waste reduction within the trust. So one of the major things that I see would drive air quality improvement within the NHS Trust in Newcastle is the optimization of its travel. And the hospital is exploring a couple of interventions, one of which is the last mile zero carbon in the last mile within the trust, and that is an approach to see how, as a matter of fact, one of the goals that's been set by the trust is to ensure that by 2025, ending of the year, which is 2026, that is, there will be zero access to emitting to internal combustion engine vehicles within the premises of the hospital, and that's quite a big task. And they have already taken active steps to implement this. There is a wide engagement with stakeholders within the procurement team, and all of the people who are act as suppliers to the trust have been repeatedly engaged on these targets so that everyone is aware and they are supporting their suppliers towards achieving this ask that they have set as a target. Bear in mind that it's not just the NHS Trust in England, in Newcastle anymore. The whole NHS, national NHS, is also driving air quality improvement as part of its green plans. And so it's actually something that it's a big ask and would cause a big improvement in air quality within the hospital and even within the society, the community that hospitals are domiciled in.
Great, thank you. And then there's a question here specifically around some of the monitoring data. Does the hospital that you've been working on have any backup emergency generators? And if so, is the testing times of these generators noted within the monitoring data?
Yes, that's actually a good question there because there are a couple of generators. I can see there's one at the RVI there just by the New Victoria Wing, and then there are at the Freeman Hospital as well. The testing times, yes, are being observed, and one of the things I am querying at the moment is to see how I can correlate the times of maintenance with the peak that I observe in some of the data that I am monitoring. But then I'm collating all of these monitoring times, maintenance times, in terms of service times for generators, maintenance times for HVAC systems to see how they impact on the air quality, and then we can then do a source apportionment and see the contributory factors of for each one of these activities using statistical apparatus like maybe a strong t-test regression analysis and the likes like that. So that's very valid point. Another thing that's been discussed is the influences behind the timings for these maintenance. Is there the contribution or consideration for air quality in your maintenance routines? Do you consider air quality? And this is so it may be a far cry. Some of these are big asks, but then if we put into consideration what times that we're observing the peaks and the impact of the maintenance on air quality, perhaps we can adjust when we do these activities at the hospitals. You haven't asked about this, but then I would highlight the fact that one of the monitoring monitoring outcomes is the fact that we observe that there is a low air quality, low pollution level at a part of the hospital where there is a lot of green vegetation, and there is high pollution levels where there is a lot of vehicular movement, where children are exposed, the children neonatal wards, the Great North Children's Hospital in particular. And so, of course, as expected, I would say it highlights for us the significance or perhaps the significance of green environment being integrated into our hospitals. Another thing I would highlight is the fact that in the monitoring data, there's a particular car park within the Freeman Hospital, just somewhere here, around here, that you can see that red dot there. The air quality level there, it's almost at par with the green environment that I talked about just earlier. And one of the things that you can infer from there at the early stages is the fact that if policies are well implemented, it can also drive home the outcomes that we desire. Because the critical thing about this particular location where I'm circling my red dot there is that it's a closed and it's a highly monitored environment where the no idling policy is very well stewarded, and it's not open to public parking. It's only open to a particular group of people within the hospital. And even though it's very active and busy, yet the pollution level is low and comparable with an area where there's a lot of vegetation. So it might mean that if we implement our policies well, we will be able to achieve better results.
That's great. Thank you very much. And of course, in your presentation, you mentioned that you're doing monitoring of both indoor and ambient air quality. We have a question here saying, what is the most common indoor air pollutants that are found in hospitals?
Well, in the hospitals, I'm looking at PM 2.5 and PM 10. That's where my focus is, and particularly indoors. Those are the focus of my monitoring equipment. You'd recall that I showed the Purple Air monitors, PM 2.5 and PM 10. Even though recently, in order to troubleshoot some of the readings that I'm seeing, to see just to further investigate what I am suspecting, I have installed also CO2 monitors from RNet, which I haven't included in there because it's still at the early stages of it, about 8 of them across both the RVI and the Freeman Hospital. So what I have as a critical contributor to pollution that I'm observing, PM 2.5 and PM 10, it appears to be the footfall at the hospital. However, I'm not ignorant of the fact that there are other contributors to pollution within the indoor environment, like the VOCs from cleaning agents and things like that. And those are also included as actions to be looked at by within the Clean Air Hospital framework, where the hospital not only purchases just any cleaning agent, for example, but cleaning agents that have less contribution to the pollutions like VFCs.
Great, thank you. That makes sense. And we've had loads of positive comments in the Q&A box about how interesting and useful your presentation was. And I wondered just to finish us off for the last question, and sorry to anyone whose question I didn't get to, but what are your future research interests, if you'd like to share with us, Tunde? What are you interested in kind of after you've finished your work in this area?
Right, that's quite an interesting question. And like I chatted to you earlier, just before the start of the presentation, the meeting. For me, this is not just a research. It's something that's driven by the desire to contribute to society and have an impact. So one of the things that fuels that is that my dad, who's now passed away, used to say something. He would say that small deeds done are better than great acts planned. And so here's my bit to contribute to the betterment of society. The work on the air quality is an ongoing work. There is a wide range of activities that needs to be done. We may not be able to cover it all in totality in 1-2 years. There is a need to continue to raise awareness. And so one of the things I am setting up as a precursor to my completing this research here is an annual webinar that I host in partnership with the Newcastle hospitals. And what that does is to raise awareness within the hospital, because yes, we are talking about all this. If the doctors and the people who are working within the hospital don't carry this burden together with us, it falls flat and we will just be doing activities. So if we can raise this awareness, we will be doing it with greater impact on not just the patients that come to our hospitals, but also on the staff that work at the hospitals and also the general public whom we're able to influence. So taking the advocacy into not just academia with evidence-based arguments, as in the monitoring, but also advocacy in terms of awareness and campaigns. And that's what I intend to do post this research. In addition, I also have an interest in risk research, which also works hand in hand together with air quality improvement, because like I said, someone is stealing our wheelbarrows and we want to ensure that we block all the leakages and ensure that they stop and our air quality continues to improve rather than decline.
Amazing. What a brilliant way to end the webinar. Thank you so much, Tunde, for that, and for your brilliant presentation. It's been really great having you with us today. And thank you to all of our attendees as well for watching. This webinar has been recorded and it will be made available on the IAQM website and YouTube channel as well. If you are watching the recording, please do subscribe to our channel, like the video and hit the bell to hear notifications of new content. And if you are an IAQM member, don't forget to record your attendance at this webinar in the CPD tool by logging into the IES members area. And if you're not an IAQM member, please do consider joining. Again, a massive thank you to you, Tunde. That was brilliant. Our next webinar will be coming up in March. Please do keep an eye on our website so that you can register for that. But for now, thank you to you, Tunde, and to everyone else for attending. Have a great rest of your day.
All right.